This is based on a technique described by Charnley in the early 50s using a frame fixateur externe. In the last 10 years there was a trend towards internal fixation for arthrodesis, and many still favor arthrodesis over joint replacement. So this was a consecutive series from 1994 to 2001, so the surgical work was actually done before my time, and we included 95 patients at the end. And excluded the septic arthritis ankle, the internal fixation techniques, and the patients who were not available for follow-up. So the mean age of our patients was about 45 years, with a large range between 18 and 82 years, with a 70% of male, and the arthrodesis was performed even in a longer range between 6 and 516 months after trauma, which an average of 129 months. Follow-up examination at mean 4 and 4 years after. So the patients, there were 43 patients with mild alignment with isolated pes equinus or complex deformities of varus and valgus component, and the remaining ROM was less than 20 degrees in 41 cases and less than 10 degrees in 37 cases. So the technique we used was the single-shot antibiotic starting at the operation, then the bilateral approach, resection of malleoli and joint surfaces, and afterwards an O fixateur with 4 Steinmann nails, 2 inserted with approximately 8 centimeter distance in the tibia, 1 in the neck of talus, and that is the difference towards the method Charnley used, 1 in the dorsal calcaneus to create a triangle fixateur, which was suggested to be more stable and put more pressure on the, more compression on the joint. So afterwards we treated them with heparin until full weight bearing. The partial weight bearing during that time with the fixateur was about 10 kilogram. At bony union at the X-ray, the fixateur was removed under protection of a walking cast, and afterwards there was an arthrodesis boot for 1 year. So we also used the alpha score for measuring and follow-up, which I think is a good score because it's some objective and some subjective patient-related topics. So in all cases of the patients we did, the index was possible. In 2 cases, soft tissue contracture by the patient was, so that a pes equinus position at the end was necessary. 2 cases had a bone transplant after unsatisfying bone union after 6 and 9 weeks. And after a mean of 12.3 weeks, the fixateur could have been removed. So we had no larger major complications with, but we had a lot of cases with pin tract infection, about 20%, which healed under conservative measures, and we had 1 bony infection that caused 3 more surgical procedures on that patient, and at least we had 1 fracture of the tibia at the site of the proximal pin later after removing the fixateur. So in 4 patients we had a non-union, in 2 patients we did a revision and 2 refused to have a revision. So overall there were 8 further surgical procedures necessary in this series. So the follow-up, as I told you, there we had twice a pes equinus position of approximately 15 degree. So the leg length discrepancy was about 12 millimeter less, and in 31 cases radiographic signs of arthrosis in the subtalar joint appeared, and 2 patients had a fusion during the first procedure and the follow-up. So the alpha score really improved from 20.7 to 69 points at the average follow-up, and the largest improvements were found regarding pain and walking distance, which might of course be the most important things for the patient at least. So we found an interesting thing about the insurance status. The patients with injury at work had a preoperative same alpha score, but statistical difference after the follow-up. The patients insured under a workers' injury compensation scheme had a mean score of 63 compared to 75 for the remaining patients. So we cannot explain why this is. So the non-union rates of the fixateur, frame fixateur are about 15%, and non-union rates of screw osteocentesis are about 5.6%. So our complication rate and further procedure rate was among the range of the other procedures mainly. The significantly worse outcome after occupational accidents, there was no medical explanation. So as we can conclude, there is a good correction of deformities, there is a satisfactory healing rate, there are good functional results and a low rate of severe complications. There are no limitations of indications even with complex soft tissue. But on the other side, we can say that there is a high rate of pin tract infections, a long period of external fixation, which is a low patient comfort. This is a costly treatment because of frequent consultations, dressing changes, and radiographs needed. So our summary would be that the complication rate and the reduced patient comfort reserves this method mainly for infected arthritis and complicated soft tissue situations. And yeah, that's it, probably. Thank you.
We have time for a few questions. Is there any question from the panel? I have one question. How big is the pin you put in the talus? What is the size of the chance pin or pin you put in the talus?
Actually, I don't know. I have to admit, I don't know the size of the Steinmann nail we use in the talus.
But it's not the Y, right? Okay. Do you have any problems with the fractures or?
No, we didn't have any fractures and we didn't have talus necrosis in our patients.
It seemed like you have a very good result. I mean, in terms of the position of the ankle fusion, do you have any tricks of the position?
No, it's just maybe that with the triangular fixation, maybe you can put a bit more pressure and more stability to the joint, and that makes a better healing rate and a better fusion rate. That might be the answer, but.
Do you temporarily fix it before you put the frame on? I mean, put anything across the joint to maintain the position before you?
So according to your lecture, you now come to internal fixation?
Yes, we in our hospital now prefer or normally do internal fixation, but with septic situations or so, we still use fixator extern or with the soft tissue problems.
Do you use any bone graft?
Yeah, autologous spongiosum for the first time, but only in 2 cases that was needed during this series.
Okay. Any more questions from the panel? Okay. I would like to thank for your excellent presentation.